Hi, my name is Peter Morley. I'm an intensive care specialist that works at the Royal Melbourne Hospital. I also have the privilege of chairing the Australian Resuscitation Council and the honour of being involved in the National COVID-19 Clinical Evidence Taskforce. And as part of that process, we set up a cardiac arrest working group. And I had the pleasure of being involved in working our way through multiple iterations to get to this final outcome. There was a diverse group of people involved in that cardiac arrest working group. They were a combination of predominantly pre-hospital and emergency-based clinicians, but also with a spread around Australia. We decided to start creating a chart for the community, in particular because there was a concern that the distress around COVID-19 might actually impact substantially on what goes on in the community. We know how important it is for the community to start basic life support and call for help early, and we knew that delays would result in worse outcomes for patients. The major differences between what we're recommending for situations where we think there may be a risk of COVID-19 are that we want people to consider that first line of danger to include thought around what's the likely community transmission. And the consensus opinion that we got to was that if you're required to wear a mask as part of your local area, then the implication is you should treat the patient as if potentially they could have COVID. Now, that means that we want you to continue to wear that mask, your mask, on your face and covering your face, your mouth and nose. But in addition, we want you to do a few other slightly different things. So as the usual process is, if the patient is unresponsive, we want you to call for help. So please do that. But in addition to that, rather than getting close to the patient to see whether they're breathing or not, we just want you to look and see if they're breathing. And if they're not breathing, start compressions. So chest compressions in the middle of the chest, hard and fast, to the beat of staying alive. And then as a defibrillator becomes available, use the defibrillator, continue your resuscitation until expert help arrives. And then obviously at the end, we want you to consider washing your hands a little bit more explicitly than we would normally. Now, we still think that this will double the chance of the person surviving to hospital discharge. So it's a really important thing. It's a very subtle modification to what we're doing. And we'd like to think that this way we'll minimise the delays to resuscitation and improve the outcomes for all patients. There is some published evidence throughout the world that there are some delays associated with the concern about COVID. And even evidence in Victoria suggesting some delays may have resulted in halving of the hospital survival rate for these people that have cardiac arrests out of hospital. So it is absolutely crucial that we do whatever we can to maintain the safety of everybody, but also to minimise the delays, to increase the chance of these people getting out of hospital alive. This sort of recommendation is relevant to all groups that are involved in providing basic life support, in other words, CPR, to patients in the community. That might be lay first aider organisations or people that are just trained health professionals who happen to be providing that sort of service. We don't usually recommend that this sort of recommendation would go to people that have never been trained in CPR, but it is that sort of message which you can get across when you ring up the ambulance and ask for help. And the dispatchers can provide you with very simple instructions to allow you to do exactly what we're talking about now. Clearly, the chance of someone having COVID is extraordinarily low in Australia. Even at the moment, it must be less than 1 in 1,000. And so the chance of an individual getting an infection as a result of this process is extraordinarily low, especially if they're able to wear a mask and wash their hands appropriately afterwards. Most of the people that are actually unwell and possibly at risk of COVID have either been tested and isolated or it's staying away from people. So we'd like to think that the chances are very, very low of anyone catching any diseases from people with CPR, and that's certainly been our previous recommendations even before COVID. So with regard to the provision of expired air resuscitation or ventilation, we know that from at least observational studies that people survive better if they do get a combination of chest compressions and ventilation. At some stage, ventilation is required for resuscitation of all patients. But we believe in the short term, the risks and the benefits are probably in favour of not delaying starting because of a fear about doing ventilation. And the benefits of just doing chest compressions will still increase the likelihood of the person surviving. The good thing about the living guidelines process is all the evidence that's being published related to transmission of disease or the impact of disease on the community is being reviewed on a continuous basis. And these guidelines will be updated as required and are certainly going to be reviewed on a monthly basis at this stage. So these community guidelines apply to the resuscitations that occur in the community, but only up until the ambulance arrives. In this setting, the ambulance services around Australia have their own specific guidelines, and the expectation is those specific guidelines would be adhered to in these situations. Overall, this is a really exciting process. I know that the COVID-19 pandemic has caused a number of concerns, but the good thing is the Australian community worked together to improve survival of people that have cardiac arrest out of hospital, and there are just simple messages that we can stick to double the chance of survival from a cardiac arrest.